The next talk is really looking at how can we assess how good our cerebral protection is intraoperatively. Here to give it is Amit Chawla, who's an anaesthetist I've worked with very closely for the last 8 years, who's very hot on that. Amit.
Thank you very much, Chris. Good afternoon, ladies and gentlemen. It's a privilege to be here, and I'll be speaking to you about cerebral monitoring during aortic arch surgery. I think I'm probably the only anaesthetist in this meeting. I have 15 minutes to cover this topic, and I'd like to start with a brief overview of physiology and the background of cerebral metabolism, which, well, I'm an anesthetist, I have to talk about physiology, which I think is essential and provides a good background to why we need to monitor the brain. And then, of course, the main substance of this talk will be the monitors available, and quite inseparable from that is the advantages and limitations of the more commonly used techniques. Of course, there are a lot many around, but I'll be restricting myself to only a few which I have experience of. And then finally, I'll sum up with my comments on where I think we stand with regard to cerebral monitoring. So let's get down to business. There are some hard facts about cerebral physiology. As you know, brain is only about 2% of the body's weight, but it receives 15% of the cardiac output and consumes 20% of the body's total oxygen, and that's at rest. The cerebral metabolism is entirely aerobic. It has no capacity to sustain anaerobic metabolism. It is simply not equipped for it. So it depends on a constant supply of oxygen to survive. Likewise, glucose is the only substrate brain can use, unlike the myocardium, for instance, which can use a whole host of substrates like lactate, even free fatty acids, ketones. As long as there's oxygen for the myocardium, it can burn anything, but the brain will only use glucose. And that, by definition, means that brain is extremely prone for ischemic injury. And here's the ultimate fact, that if the cerebral blood flow and oxygen supply is interrupted for even 10 seconds, it will result in unconsciousness and cell death within about 4 minutes. And that's at normothermia, of course. So with this background, let's move on to the different monitors we have for cerebral function. Broadly speaking, I'll divide them into two groups. That first is monitors for cerebral perfusion, of which there are about 3 which I'll be talking about, and then monitors for cerebral function. And there are just a couple I'll briefly touch upon. So the first one is the most commonly used monitor, which is near-infrared spectroscopy, or NIRS, which is, I think, pretty universally used for aortic arch surgery now, to the point that it would be considered as a standard of care. And the second one, which we use quite a lot of in our practice, especially in patients having hypothermic circulatory arrest, is jugular venous oxygen saturations, or SJVO2. And the third one, which we don't use a lot of, which is why I've put it third, Personally, I would consider that as the second, perhaps most important monitor, which is transcranial doppler. With regard to cerebral function monitors, what I will cover would be mainly processed EEG, or bispectral index, which is actually an extension of our anesthetic monitoring, which we quite routinely use for all our aortic arch patients, or in fact, for most of our cardiac patients. And the other one which is around, which we don't use, and I have no personal experience, which is evoked potential monitoring, which is mainly either sensory evoked potentials or auditory evoked potentials. So as I said, I have no experience of that, so I will not discuss the evoked potentials any further. But the main substance of my talk will relate to the cerebral perfusion monitors. So let's start with the main one, the near-infrared spectroscopy. And like I said, it is the most widespread monitor in use. The principle of near-infrared spectroscopy is actually quite simple, that you have the near-infrared light, which has a wavelength of between 700 to 1100 nanometers, and that can be used to measure oxygen saturation in the cerebral microcirculation. Now, that is a very important point to appreciate. A lot of people think that with near-infrared spectroscopy, you're actually measuring the cortical oxygen saturation in the cortical tissue or the neuronal tissue of the brain. That is not true. It is actually the cerebral microcirculation, which is 30% arterial and 70% venous. So what you're actually measuring is a sum total of the oxygen content in these two vascular beds. And therefore, the value which you get is more like between 60 to 80% is the normal. Now, there are 3 features of near-infrared spectroscopy which lends itself to for monitoring for cerebral perfusion. And the first is that both oxyhemoglobin and deoxyhemoglobin have different absorption spectra in the infrared region, and that's actually just an application of the Beer-Lambert law, which we use routinely in pulse oximetry. The difference is that we are not looking for a pulsatile circulation, we are just looking for the concentration of these two components of hemoglobin in the cerebral microcirculation. The second feature is that infrared light actually has very good tissue penetrability, so it can go through the scalp, skull, and the cerebral tissue. And third, and probably the most important feature, is that penetration actually increases with greater separation between the infrared source and the sensor. And you'll see that in the next slide. So here you can see that that's the two sensors applied to the patient's forehead. So essentially, you're monitoring the frontal lobes of the brain. And here you've got the light source or the infrared source, and there are two sensors, a shallow sensor and a deep sensor. The shallow sensor will, as you can see, it'll measure the oxygen saturation through the skull, scalp mainly. But the deeper sensor will measure the oxygen saturation not only through the skull, scalp, but also through the cerebral tissue. And to get the actual brain oxygen saturation, what is done is you digitally subtract the information or the data from the superficial sensor, of the superficial sensor from the deep sensor. And what you end up with is just the brain oxygen saturation. So this here you can see, this is our setup for cerebral, for near infrared spectroscopy in our theaters. So you can see the patient's head with the two sensors applied, and that's the INVOS monitor or the near infrared spectroscopy monitor. That's just placed, it's quite a compact and a portable screen, which can be placed next to the main monitor so everyone can see it, including the surgeon and the perfusionist. And that's the normal values. And you can also appreciate that you have two channels for the right and the left side, which are separately monitored. And you also get a display of the trend, which is monitored all the way through. Now here we have a situation where the nurse is actually giving you some very valuable data. This is, as you can see, everything's going smoothly here. We started, when patient's been on bypass, started circulatory arrest. And so this is a patient having a hemiarch replacement under moderate hypothermic circulatory arrest with antegrade cerebral perfusion. And suddenly the SATs drop. The perfusion starts complaining that he's not able to get his flows through, and the line pressures are very high. And you can probably see in the next picture what the problem is. So this is the side arm of your arterial cannula through which you're actually feeding the head vessels, and there's a kink, and there's a very rapid drop. And as soon as that was fixed, the SATs picked up, and we went along. So advantages of near-infrared spectroscopy. The first is that it is non-invasive, and it allows for bilateral monitoring. Second is it is simplicity itself. It is easy to apply and interpret. Once you've plugged your electrodes on, it's as easy as pulse oximetry to interpret. So the normal values are between 60 to 80%. And any drop in a 20% drop from baseline or a sustained drop of more than or of less than 55% should ring alarm bells and should be treated. The other advantage is that it allows for continuous and uninterrupted monitoring. And most importantly, it works in a non-pulsatile state. So it is useful for during cardiopulmonary bypass and also during circulatory arrest, whether you're using antegrade or retrograde cerebral perfusion. And finally, it is portable. Once you've plugged the monitor on, the monitor can follow the patient, if you want, from induction all the way down to intensive care unit. Though I have to say, we only use it intraoperatively. Obviously, there are limitations and disadvantages. The first is probably the most obvious, that the monitoring is only limited to the frontal lobe, and therefore you're only monitoring the anterior cerebral artery, which normally carries only about 20 to 25% of the blood flow to the ipsilateral cerebral hemispheres. So you're not monitoring the most important vessel, which is actually the middle cerebral artery. So that is one problem. Secondly, it cannot diagnose the etiology of desaturation. It will not tell you the difference between, you will get a drop, but it will not tell you whether the drop is embolic or because of just a hyperperfusion or drop in perfusion pressures. It will not differentiate between the two. Third, changes in the ratio of arterial to venous blood can cause errors. For example, anesthesia-related or positioning-related changes between the arterial and venous components in the microcirculation will reflect on the value of your NERS signal. And finally, diathermy can also cause interference, which I don't think is a real problem, because when you really need it, which is during bypass or during circ arrest, I don't think diathermy would be used at that point. Okay, now moving on to the jugular venous oxygen saturation. This is, like I said, the second most commonly used monitor in our institution. And we use it for monitoring mostly all our circulatory arrest patients, particularly patients having deep hypothermic circ arrest. The idea is to place a catheter backwards through the internal jugular vein into the jugular venous bulb, usually on the side which we use for central venous cannulation. And it could be either used for intermittent monitoring, which is what we do, or continuous monitoring if you have the kit for putting in a fiber optic catheter retrograde, of which I believe Edwards Life Sciences does make a kit which is useful for continuous monitoring. So the normal range of jugular venous oxygen saturation is between 50 to 75%. The advantages are that there is a strong, albeit inverse linear relationship between the cerebral metabolism and jugular venous oxygen tension. So as the cerebral metabolism, as the metabolism decreases as a result of, say, hypothermia, the jugular venous oxygen tension will rise. So the most important use for us is that it is useful in determining the endpoint of cooling before initiating circulatory arrest. So when we sort of get down to a temperature of around 20, we start drawing samples. And when you get a jugular venous oxygen tension of about 95%, or the blood is arterialized, we know that pretty much the brain is not taking any oxygen from the blood and you can switch off. It's also believed that, though I have no personal experience in this, that you can also use it for monitoring antegrade cerebral perfusion. And with that, if you can maintain, or you should target a jugular venous oxygen saturation of about 90%. So moving on to limitations of jugular venous oxygen monitoring. The first is that it is invasive, as you would expect, and it only allows for unilateral monitoring. You can only monitor one side. You don't know what's happening to the other side of the brain. It only detects global oxygen supply balance, and it'll not pick up any regional ischemic events. And third, if you are using continuous monitoring, then it is susceptible to a drift, so you do need to recalibrate your monitor frequently. And finally, there is a risk of contamination from extracranial veins. So if you are using intermittent technique, you do need to draw your samples slowly. And if that is not done, then you can actually end up with wrong values. Now coming to transcranial Doppler, the idea is to use a low frequency, which is a 2 megahertz pulse wave transducer, to measure blood flow through the middle cerebral artery. It's actually the velocity which is being measured, not the blood flow per se, through the temporal window. Now, the reason you have to have a 2 megahertz transducer is that ultrasound is not good in penetrating through bone. The higher the frequency, the less the penetration. So which is why you use a low frequency transducer, which hopefully will have a better frequency. The advantages of transcranial Doppler are, one, it is completely non-invasive, and you can use it for bilateral monitoring. Two, it monitors blood flow in the middle cerebral artery, which, as we've said, is the most important vessel in the brain, as it supplies about 70% of the blood supply to the ipsilateral cerebral hemisphere. It is excellent for detecting embolic events, and these are known as hits, or high intensity transient signals, and I'll show you in the next picture and the next slide. And it is also useful to detecting instantaneous changes in cerebral blood flow. So this is what a normal signal looks like, a sort of a normal pulsatile flow, and this is what it looks like, basically bursts of emboli coming in, and this is what is referred to as high intensity transient signals. Limitations of transcranial Doppler, the monitoring and interpretation, as with most ultrasound modalities, is entirely operator dependent. So depending on how good your sonographer is, your data or the information that you get can be varied. Now, only 2 vessels can be insunated, which is usually the middle cerebral artery, which is not bad because you are getting the most important vessels. And 10% of the patients cannot be assessed through a temporal window, so only about 90% of your patients you will be actually able to use this monitor. And it is not terribly useful for low flow states or no flow states, for example, either for complete circ arrest or when you have retrograde cerebral perfusion with a very low blood flow. So it'll probably not be very useful in those situations, unlike a NIRS or infrared spectroscopy. Coming now down to the cerebral function monitors, which I said I will talk about only one of, which is bispectral index or processed EEG. This actually is just an extension of our regular anesthetic monitor, because we use this for monitoring anesthetic depth. Basically, analyzing a raw ECG signal is extremely difficult, and you really need a neurologist to do that. And we don't have the facility for that, so we just use a bits which would basically process the frequency and the amplitude of EEG signals and display it in a simple number, usually a number between 0 to 100, where 0 equates with complete electrical silence in the brain and 100 equates to being fully awake. So the main use is to confirm electrical silence during circulatory rest. The problem is that it is influenced by anesthetics and hypothermia, and indeed actually hypoxia. If you make the patient completely hypoxic, you will get a straight line. And finally, it lacks sensitivity for the activity in subcortical structures, and it monitors only one hemisphere. So that is unfortunately a problem. So this is basically what it looks like when you're monitoring the BIS. Imagine if you didn't have this number and you had only this trace to go by. I think very few people would be able to make sense out of that, which is why we prefer to have a number which gives us an idea, something to quantify the ECG or the brain electrical activity with. And of course, it shows you the trend down here. So coming to conclude, I would say that cerebral monitoring during aortic heart surgery is essential. If you don't monitor the brain, you can't protect it. The ideal monitor would be a non-invasive monitor which provides continuous assessment of cerebral perfusion and function, but sadly, there isn't one. So no single monitor is perfect at the moment. So whatever you do, choose a monitoring based on your familiarity, the risk assessment, and the planned surgical technique. This is a F-117, a Nighthawk stealth fighter. If you can't detect it, you can't fight it. Likewise, cerebral ischemia, if you can't detect it, you can't prevent it. Thank you very much, ladies and gentlemen. And on a lighter note, select your monitoring carefully, or you'll end up with some serious cerebral damage. Thank you very much, ladies and gentlemen.
Thank you very much indeed, Amit. Do we have any questions for Amit?
Yes.
John.
I'd like to take issue in a friendly way with one of your conclusions. Can you explain to me why it's not true the following? If the brain is cold, it's protected. Tell me why that's not true.
Well, you can't be sure that all areas of the brain are cold, one. So you need to know one way or the other that the area that you're interested in is actually cold and is protected. So I think you need to be able to monitor what you're protecting. And I think that is the bottom line. It is sad, it's unfortunate that the monitoring tools that we have today cannot monitor the whole brain. And that the reason for that is very simple, that brain itself has a very complex blood supply, and you cannot monitor each of these vascular areas. So we use brain function monitoring as a surrogate, or brain, either that, or we actually try and measure some form of perfusion in these areas. So I think you should try and monitor it, and just relying on hypothermia alone is not enough. We time and time again see patients we've cooled them down, we've switched the circulation off, we're down to about temperature of 18 degrees, and they still end up with a stroke. Why? If it was as simple as just cooling the brain, everyone would be happy. We wouldn't be wasting our time talking about monitoring. Yes?
Thank you. Thank you very much for your interesting talk. With regards to NIRS, there's a number of factors obviously that affect the bypass factors, anesthetic, and surgical factors. So when you see a drop in NIRS reading, what do you have an algorithm? Who intervenes? The surgeon, the anesthetist, or the perfusionist, or all of the above? Do you have a treatment algorithm or intervention?
Well, it depends what stage of the procedure you're at. If it's before bypass, then obviously it'll be the anesthetist who would have to intervene. If you're on bypass, and depending on whether you're on complete circulatory arrest or whether you have antegrade cerebral perfusion going or retrograde cerebral perfusion, you would try and assess what the problem is. As I showed you in one of my slides, that when we were on bypass with antegrade cerebral perfusion, moderate hypothermia, and suddenly the SATs dropped. So you try and sort of troubleshoot from one end, obviously starting from the end of perfusion. So we had an antegrade cerebral perfusion. So we worked our way from the cannula, from the pump flow. The perfusionist said that there was a lot of resistance, the pressures were high, the flow was down, and then we worked our way down, sort of down the plumbing, and then you find the problem somewhere.
Much as I'd like to carry on, I am aware that we're about 30 minutes behind with that rather prolonged coffee break. So sadly, I think we must continue. But thank you very much indeed. Thank you. And I'm going to hand over now to Jeff.